Oh, 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 see. Hello, good morning, everyone. Hello, Cherry. Hi, Amanda, Alfred. How are you guys doing?
Good. How about yourself?
I'm doing
Doing
all right.
good.
Thank you for asking. Just another day.
Yeah. Happy Friday.
Happy Friday.
Yeah, Friday, exactly. Yep. Just trying to have that feeling that it is Friday. Doesn't look. I just don't feel like that because I have
Yeah.
things to do. So I don't think it's gonna be my Friday.
It's 3-day
That's
weekend
all
too.
good. Yeah, it's all
Labor
good.
Day on Monday, right?
Yeah. Technically, yes. I'm off. Practically, I'll be catching up on things
Mm.
with my other stuff. So there are things like last few days. I mean, tied up in other places and was not able to do what I should have done or supposed to do at the pharmacy part. So uh, I'll utilize uh, the weekend and the holiday to catch up there.
Yeah. Because I think we all have homework to do this weekend.
Yeah, student life, it's just, just to kind of feel, get like, yeah, I have day off, but technically there's no day off, right? For student
Yeah.
life. Yeah,
Yeah.
that's the sad part, but it just, it's just a time for the time being. It's really well worth investing. There's no other best investment exists in this world other than investing in your own education. Nothing else. You can't ever be wrong in this. Never. Okay, we are still missing students. Let me just refresh so that I'm not old page. So I believe we are missing 5 students. All right, these are the students showing absent in the course key. Bella, Olga, uh, Lee, Trina, Taylor. Oh, no, I'm sorry, not Taylor.
Trina's trying to get. She's just
Yeah,
trying
I'm
to figure
sorry.
out
Taylor's
her
here.
outlook.
It's Jenny, and then Rabia.
Professor, can you please log me in?
Absolutely. How can I say no? All right, ma'am, you are checked in. So, any question, guys? Just we'll give a minute or two.
Professor, this is Fatih. I'm going to log out because it logged me in my web. I'm going to log out and log back in from the app.
All right, as you wish.
Trina's having some problems with the link, so she may take a second, but she's here.
Oh, okay. Thank you. Excuse me. I'm not sure why, but there's few cameras still. Like yesterday, I was looking at showing just the name on it. Do you guys see actually the Christian or Munir?
Yeah, we see him.
You see him? Huh.
Yeah. Yeah, I see him.
That's weird. Okay, many of you did send a message, and I saw that message. You guys were asking that you were not able to find the recordings, right? So we're still not able to find it?
No.
No.
Okay. I tried, guys, to compress the file because it was 1.38 gigabytes or something. Couldn't attach anywhere. And I tried to compress it. I had to cut it. I started it last night and I saw it this morning. It's still processing. So let me see if I can show it to you guys. Let's just give me a sec. Excuse me.
Olga and Trina are still having a little bit of problems getting into the class, so they're going to be a second.
Okay, thank you.
I made it. I figured it out.
Perfect. Thank you.
Okay, perfect, Trina. Thank you. So, did you check in? Yeah, yes, you did. Okay, so we are missing Bella as well as to Uncle Lee and Jenny. Could someone please drop a text for them in your group chat?
Professor Shra, I think Jenny mentioned to me she wouldn't be here today.
Okay,
I
yeah,
think she said she messaged you.
yes. Okay, thank you for reminding. Yes, she did.
You're welcome.
Okay, perfect. There's and just a quick moment. You know, sorry. So let me just respond, guys. Yeah. Okay. So I believe you guys did mention that you guys, I think, discussed, and then I believe it was Harjot and who else that who kind of offered their kind services
It
to
was
be class
Zara.
reps. Who is it? Harjot and who else? I'm sorry?
It was me.
Zara?
Yes.
Okay, now what I want you guys to do to please all of you, if you could, if you all agree, if you could just raise your hand in, I mean, the virtual hand, okay? You don't have to actually do that. So all of you, if you could do that, and let me see real quick so that we can make it official, okay? And if you don't,
Raise your
just
hands
send
for
me a
what?
separate message. I'm sorry?
Wait, raise hands for what?
For the class reps, remember that I was informed that it was um, Harjot and Zara that
Oh, I thought we were talking about the video. All right.
no. So I'm just taking a look. So majority, I see that yes, pretty much everybody agree with that. Okay, thank you guys. So you can get your hands down, you'll be tired, okay? So thank you. So we'll make it official. So Harjot and Zora, so they will play that role. Congratulations, both of you. Sorry, give me a moment. Okay, sorry about that. I'm back. Okay, so we are over with that part. Now, who are we missing? Okay, anybody missing the course key, guys? Is everybody here? I don't like it's glitches here on Teams. Just double check. So I'm still seeing Bella and Lee. And Jenny told me, so 2 students who are absent. Anybody heard? Any word from them?
From who were the two?
From Bella and last name Lee?
Bella and Lee. Okay.
Yes, please. All right, so let's move on.
A quick question.
Yes, go ahead.
Go ahead.
What's the word on the recorded lectures?
Okay, recording?
Yeah.
Okay, let me let me see if I can show you that, okay? Okay. Now here. Okay. Do. And here. Oops. Share. Where is the D and do. Okay, do you guys see here, like in my calendar, this is how it shows. And if you look at it on the chat, do you see here that lecture link? So this is for like today, right? The recording will show up here when you click on the left-hand side. Even the files for every link for that day is different. Like here, this was from yesterday. This is the office hours link. So on the left-hand side, right here, you see here it's a Fremont BSN 3. On the top, it says lecture link. And here is the date, 29th. And this is where the recording is. It shows 149 in here, but when you click it, there is part 1 and part 2. And you can see actually the left one, which shows as part 1, that is a complete recording.
Professor, it says we don't have access to it because we're not a part of the original team.
So if you click on files, look here, the recording showing up. It doesn't show like that?
No.
No, because it says that our access is denied. I tried yesterday and it said that you have to be like VIP or something.
No, and you're using your school email to log in either
Yeah.
app or wherever you're doing, right?
Yes.
Okay. Can you please send me like a screenshot of whatever the error messages you're getting?
Yes, I'll send you a picture of it.
Send me that and let me follow up on that, okay?
Is there any way to just like send that through like Canvas or no?
I tried, that's what I was telling earlier, that I tried to do it, but it just didn't go through. Yeah, the files, even though I zipped it, it still didn't go through.
Oh. What about
Yeah,
normal email? No.
Yeah, no, it doesn't happen. but it just on Canvas it didn't go through. One, I mean, I'm gonna try two things today. Okay, one is that I will follow up, with teams on that. So what they have to say if they figured out something. Number two is that I will try to attach it in the email.
All right.
Okay.
Thanks.
So that might work.
All right.
Yeah, I tried last night. It just kept processing, didn't let me do anything.
And then
Oh,
Sorry. I noticed when you were like on the chat, it was saying all the names of the people and it was saying no longer has access to the chat. If you look on your end, is it possible if you could just like add us to the chat again? I don't know how it works.
I
So.
have to, yeah, I have to figure that. I have to ask like what it is. But
Mhm.
usually, I don't know why it just says after, that it will expire when the recording shows up in the chat. But after some time, it does show up in the under the files, under the files. Um, I don't know. To be honest, it's just something different than Zoom. Um, but I'll figure this out. I mean, in any way, I'm going to try to attach that yesterday's lecture and then today's lecture as well, possibly in two separate emails recordings so that at least you can have it. And I'll keep working, see like how can we figure this out. Okay?
okay. Thank you.
You're welcome. Okay. Okay, do you guys see my full screen?
Yep.
Or is it split? It's not split, right?
No, it's a full screen.
Okay, thank you. I have two screens and split and sometimes accidentally share the wrong one. Okay, so today as well, we're gonna go over three chapters, okay? Three chapters. Now they're also kind of a little complex, and complexity is because of you guys being the generic cohort. Because unfortunately, there's not much, um, you know, basics in any class you learned previously. So that makes it a little bit more challenging. But we'll go over that. Okay, so first chapter is anti-dysrhythmic drugs. So the drugs which acts against the dysrhythmia. Rhythm, look, in body, everything is supposed to work normally, but in disease condition, it doesn't. So that's called dys. It's abnormal. Rhythm is not normal, called dysrhythmia. Now, what can happen? It could go high, it could go low. Nothing else, right? Nothing else can happen. Could be fast, it could be slow. Or actually, I'm sorry, it could be variable. It could vary both sides. Okay. So we'll talk about those conditions and then the solution, the medication. And while we are giving them the medication, what to watch for? Therapeutic effects as well as the adverse effect. Always expect the unexpected. Be prepared for that. Okay. And then we'll talk about the important aspects which are important for nursing care plan or following the nursing process. Okay. Here you go now. Let's first talk about dysrhythmia, right? Dysrhythmia, another name, arrhythmia, same thing, right? So what it's telling us, it's just saying that there's a disturbance, there's an abnormality in the heart's normal rhythm. That's the only thing. Thanks, Arjot, for sending the picture. I'll take care of that after the lecture. So any deviation, okay, on either side, fast, slow, or variable. Now this affects how the heart functions. Now, from where they can originate? So they can originate from the atria, which is the upper chambers of the heart, right? Or the ventricles, which are the lower chambers, or from the nodes which generates or conduct the electrical impulses, your SA-AV nodes. They could be benign, like, not much of an issue, but could be life-threatening, depending on what type they are, how serious, severe they are. So different scenarios. Now, types of dysrhythmia or arrhythmia. As we said, it could be slow, fast. Let's talk about them real quick. For example, number one, supraventricular tachycardia. Now, tachy means fast. Brady means slow. Okay? We're talking about tachycardia, fast. And the prefix is saying supraventricular, above the ventricles. Okay? Now, what is there? So originates above the ventricles, usually in the atria or the AV node. Now, is there an example which can kind of, correlate so that we can remember which one are those? Yes, like your AFib, atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia, short name you can remember as PSVT. So these are examples of supraventricular, above the ventriculars, originating from atria or your AV nodes. Now let's talk about ventricular tachycardia. Now, once again, it's a tachycardia, means fast, but where? From the ventricle. So they originate from the ventricle. Okay, so it can lead to ventricular fibrillation. Okay, now on the other end, if we talk about slow, bradyarrhythmia, okay? Bradyarrhythmia, when the heart beats slowly, usually less than 60 beats a minute, right? Now, it could be sinus bradycardia. It's slow heart rate originating from the sinus node. It can be normal in like athletes. It could be just normal for them, but may indicate an underlying heart problem if it's symptomatic, if they are experiencing symptomatic. Okay, then heart block. Now this is a condition where conduction of all the impulses, the electrical activity, the impulses through the heart gets delayed or gets blocked. Okay, it could be the first degree, second degree, third degree based on the heart blockage. Okay, then another type are premature contractions. Contractions happening prematurely. So what that causes, so these are extra beats which originates from the atria. Those are the ones causing premature atrial contractions, or if the ventricular is doing that, then they are premature ventricular contractions, wherever it's happening. Okay, now if we talk about fibrillation, fibrillation is rapid and irregular heartbeat. Okay, it's rapid, fast, as well as irregular. It's not in a regular pattern. What it could be, example, AFib, atrial fibrillation. This is one of the most common and serious dysrhythmia. What happens? Rapid and irregular beating of atrial chambers, upper ones, atrial chambers. Now what happens? It can lead to increased risk of stroke and heart failure, AFib. Heart is beating fast and irregular. Where? Problem, where the problem? Atrial, the upper chambers. Everybody know where atrial and ventricles are, right? Atrium one on the top, ventricles on the bottom. Okay. Now, if we talk about ventricular fibrillation, VFib, we talked about AFib earlier. This is VFib. Now, this is also life-threatening condition where the ventriculars are doing what atrium was doing earlier. Okay. Now, because of that, they are not supplying the effective amount of blood. The circulation is not normal. Okay, that's when you need a defibrillation. Now, why does it happen? What are the reasons behind these? Patients with heart conditions, such as coronary artery disease, somebody has heart attack, they have some issues with heart valve, heart failure. These are conditions can cause dysrhythmia. Another reason, imbalance in electrolytes such as sodium, potassium, magnesium, calcium, that can alter the electrical activity in the heart muscles. That could be reason. Okay. Then medication, certain medication can change it, like your beta blocker, digoxin. They can alter the heart's cardiac or the heart's rhythm. Then substance abuse, people using certain drugs excessively or illegal drugs, cocaine, amphetamines, those can cause that as well, or consumption of alcohol, caffeine, nicotine, that can also do that. Then some other conditions, underlying conditions, for example, thyroid condition, especially hyperthyroidism, okay, that can cause the problem as well. People with hypertension can cause as well, or it could be simply genetic. Okay. What are the signs and symptoms associated with dysrhythmia? Like, hey, we're talking about this, but what does patient show? Maybe palpitations, dizziness, they're feeling lightheaded, they're feeling short of breath, they're tired, fatigued, maybe chest pain, fainting. Those are common signs and symptoms associated with that. Well, the next question is, how do you diagnose it? How do you diagnose it? Well, EKG, okay, that's electrical activity of the heart. That's what the graph draws, and you can identify there. Then there is a Holter monitor, which is a portable ECG device, which patient wears for like 24 to 48 hours to kind of get a better, more clear picture. Okay. Echocardiogram, the ultrasound of the heart. Stress test, where they kind of hook you up with monitors, and then they ask you to kind of start walking and then running. They increase the intensity on the treadmill, also called the treadmill test. But some patients, including myself, because I had a back injury years ago, I can't run on treadmill. So in those scenarios, they can actually infuse a drug to pace up your heart to assess similar way. Okay, and now comes the treatment. How do we manage it? First thing is a lifestyle modification, diet, weight, no alcohol, quit smoking, managing stress, managing weight, all those kind of things. After then comes your drugs, which are antidysrhythmic or antiarrhythmic drugs, and we're going to talk about that. Okay, you guys get a little bit of kind of picture, like what we're going to talk about. If not a lot, but hopefully a little bit. Zara, you have a question?
I do have a question.
Mhm.
So would the drugs happen after all of these tests and reformation, or would they happen with the reformation? Like, let's say someone needed to lose weight for a healthy heart. would they take the drugs alongside losing weight, or would they do it after they lost the weight?
Okay, the first thing is the least, and that is non-pharmacological intervention. That's what you start. But if the patient is at high risk, then you combine both. Does it make sense? It depends on the severity of the symptoms, how
Thank
much
you.
risk the patient has. You're welcome. Okay. Now, we talked about this already. Now, a term called action potential. What is action potential? Action potential is rapid, but it's a temporary change in what? The electrical membrane potential. It's the electrical conductivity of a cell where it's occurring, usually in the nerve and muscle cells. It's temporary, rapid rise and then fall. Now, it begins when the cell membrane depolarizes. After a threshold, there's a stimuli and then depolarize. So this triggers the voltage-gated sodium channels to open and allowing the sodium ions to flow into the cells, which causes depolarization. Now, as this membrane, the potential reach its peak, the sodium channels, sorry, the sodium channel close and the potassium channel opens. Okay. Now, those channels now allow the potassium to flow out the cell, which causes repolarization. Okay. And during that, the membrane, the potential, just for a brief period of time, it becomes more negative than it's the resting state. We call that a hyperpolarization before returning to the resting potential. So this whole sequence, it allows the action potential to propagate along the cell and enabling that signal transmission in neurons, which causes what? The contraction in the muscle cells. Okay. Now, I want to give you a little bit understanding of EKG. Okay, it's good to know. Most likely, I'm not going to give you a question to identify that, but I want you to know this. It's important. Okay. Now, what is EKG? EKG is simply a graphical representation of your heart's electrical activity. That's what it's drawing, right? How the heart muscle is moving during each heartbeat, and each part defines something. For example, you see here P and then Q, R, S, and then T, and then I will again start with P, Q, R, S, T. Okay, this is how the normal activities happening. Now, the P wave, what is P wave? The P wave represents atrial depolarization, which is electrical activation of the atrium. The top one. This is where the activity happening. This is what defines here. Now, normally, this is how it will look like. A small, rounded, kind of positive wave. How long it lasts for? Maybe 0.10, 0.12 seconds or so, so it's in milliseconds. So if this is abnormal, it's kind of giving you the atrial enlargement. It could be AFib or AFlood. Okay, because remember, this is with atrium. So conditions associated with atrium. Now, here is the QRS complex, QRS complex. Now, that complex represents ventricular depolarization. This is the ventricles, these, the bottom one, ventricles. Okay, activation of ventriculars. Now, Q wave is a small, it's a negative deflection before the R wave, okay? And the R wave, this is a large positive deflection following the Q wave. And then your S wave, it's also a negative deflection, which comes after the R wave. Now, normally, as it's shown here, sharp, narrow complex, it's going up and down like a peak, okay? Usually, once again, 0.10 seconds or so. That's what I lost. Now, if this peak, QRS, it becomes wider, okay? Now, what does it tell you? Maybe issues with the ventricle, like ventricular hypertrophy, or premature ventricular contractions are happening, okay? If the Q waves are real deep, the Q waves, these, if they're deeper, pointing real going down than usual, it may indicate the patient probably, it's not that happening, maybe experienced a heart attack, a prior myocardial infarction. Okay, and now the T wave tells you ventricular repolarization. This is the recovery phase when the ventricles are getting ready to contract again. Right? So T wave, if they are inverted or they are flat, that's telling you ischemia. The heart muscles are deprived of oxygenated blood. Telling you what? When does that happen? Heart attack, right? Heart attack. So these are some kind of indicators to identify the issues associated with heart while looking at the EKG. Now, real quick, I'm going to show you a short video so that you can understand. Once again, I'm not going to ask you in the exam, but I just wanted to share it with you because this is going to go along with you long way. Okay, so it's great to learn how to interpret the EKG. It's a very simple method. Okay, so please watch this.
We can't hear the video. Professor, you're
Professor,
muted.
you mute. Yeah.
I'm sorry, you can't hear it?
No.
Okay,
No.
okay, I'm so sorry. Okay. Okay, are you able to see the full screen again?
Yes.
Yeah, we can see it.
You see it? Okay.
This video is for you.
Yeah, we can hear it.
All right, guys, this is the 6-step EKG interpretation. So before we talk about the actual steps, we're going to discuss important concepts that will help us have a better understanding of what's going on inside the heart as it generates a heartbeat. The first concept that we are going to discuss is the conduction system of the heart. Now, the conduction system of the heart is pretty much these special cardiac cells right here that are responsible in conducting signals that cause the heart to contract. The first cell is called the SA node, right here, or the sinoatrial node. By its name, sinoatrial, this cell is found within the right atrium of the heart. This is also known as the natural pacemaker of the heart, because this is where the beginning of the conduction takes place. So from the SA node, the conduction goes to the AV node, or the atrioventricular node. By its name, this can be found within the border of the right atrium and the right ventricle. The AV node is also known as the gatekeeper of the heart. And the reason being is that it gets to decide whether what impulse to let through. So, if the SA node generates a weak impulse or there is a block here somewhere, the AV node will perceive that and will decide not to let the impulse go through, and instead it will conduct its own impulse. So from the AV node, it goes to the single structure right here called the bundle of His. And from the bundle of His, the cells will continue and will bifurcate into two separate cells, one to the left and one to the right. And this will now be called the left and right bundle branches. And from the bundle branches, they will extend within the apex of the heart. They will be called the Purkinje fibers. So again, the conduction system of the heart begins at the SA node, goes to the AV node. Next is the bundle of His, the right and the left bundle branches, and then eventually Purkinje fibers. So another concept that we need to discuss will be the inherent rate of these cardiac cells. When you say inherent rates, these are pretty much the heart rate we generate depending on which cardiac cell sends an impulse. So for example, if the SA node starts it all and it goes all the way to the Purkinje fibers, this will generate a heart rate of 60 to 100 beats per minute. It starts from here, goes all the way to the Purkinje fibers, that will generate a heart rate of 60 to 100 beats per minute. However, for some reason, if the SA node fails or there's a block somewhere here, then the AV node will kick in. It will generate its own impulse. And when this happens, the AV node will generate a heart rate of 40 to 60 beats per minute. And that also includes the bundle of His. The bundle of His also will generate its own impulse, and it's enough to make 40 to 60 beats per minute. And if the AV node or the bundle of His fail, then the left and the right bundle branches and the Purkinje fibers will generate their own impulse, and they have the capacity to make a heartbeat up to 20 to 40 beats per minute. So now, let us talk about EKG. It has different parts. We will start with this small bump right here called the P wave, followed by this tall structure right here called the QRS complex. And lastly, the last bump after the QRS complex would be the T wave. Let us discuss them one by one. Let's start off with P wave. The P wave represents atrial depolarization. During atrial depolarization, the two atria are contracting. Next up, the QRS complex. Now, the QRS complex represents ventricular depolarization. During ventricular depolarization, the ventricles of the heart are contracting. Depolarization is for contraction. So how would you know which one is which? That P wave is for atria, while QRS is to ventricles. So if you look at the diagram right here, the QRS complex, it kind of looks like an inverted V. So V for ventricles. So when you see a QRS complex, think about ventricular depolarization. So lastly, we have the T wave. The T wave represents ventricular repolarization. This is when the ventricles are relaxing. Keep in mind that every depolarization is always followed by repolarization. So for every contraction will be followed by relaxation. That being said, the question is, where is atrial repolarization? So if QRS represents ventricular depolarization or contraction, and T wave represents ventricular repolarization or relaxation, then where is atrial repolarization if this is depolarization? Well, it can be found within the QRS complex. As you can see, the QRS complex, it's a tall structure. Because ventricles tend to contract stronger than the atria, they tend to mask the atrial repolarization. And so, that being said, atrial repolarization and relaxation takes place after the P wave, which can be found within the QRS complex. Now, as a review, P wave stands for atrial depolarization. The QRS complex represents ventricular depolarization. The T wave represents ventricular repolarization, and the atrial repolarization is covered by the QRS complex. You can't see it, but it exists. So now let us talk about the segments and intervals in the EKG diagram. There are a bunch, starting off with the PR interval, the PR segment, the QRS complex, the ST segment, and the QT interval. But to make it easy for you guys, we are just going to talk about the PR interval, and the QRS complex. These are all you need to do the EKG interpretation. The other segments, they are important too, but we don't really need them to interpret an EKG faster and more efficient. So this is your typical EKG strip. In an EKG strip, we have a big box. And inside a big box, we have 5 small boxes. Each small boxes is equal to 0.04 seconds. And so if in a big box there are 5 small boxes, that means that one big box is equal to 0.20 seconds. But really, as long as you know that one small box is 0.04 seconds, we're good to go. So let us get on with our 6-step EKG interpretation. First up, we have to identify and examine the P waves, measure the PR interval, measure the QRS complex, identify the rhythm, determine the heart rate, and interpret your strip. And we're going to talk about them one by one. Let's start off with identify and examine your P waves right here. The normal P wave would be present and upright. If the P wave is absent or inverted, then it could indicate a form of dysrhythmia such as a junctional rhythm. Next up, we are going to measure the PR interval. PR interval is the distance between the beginning of the P wave and the beginning of the QRS complex. What we do is we count the number of small boxes in between and multiply it by 0.04 seconds. Our magic number for the PR interval is 0.12 to 0.20 seconds. Anything more than 0.20 seconds could indicate another dysrhythmia such as heart blocks. Third would be to measure the QRS complex. Just like the PR interval, we are going to measure the small boxes in between the QRS complex. Our magic number is 0.06 to 0.12 seconds. Anything more than 0.12 could indicate a dysrhythmia such as a PVC. Number 4 is we have to identify the rhythm of our strip. It could be regular or irregular. And the way we do this is we measure the distance between R's and R's. Some people use calipers to do this, but really all you need is an index card. Mark your R's and march them with the rest of the R's. If they have the same distance, then your rhythm is regular. Otherwise, they are irregular. Fifth step is when we identify our heart rate. Now, before we calculate our heart rate, it is very important for us to know that our EKG is a 6-second strip. And the way we will know this is when we find these 3 lines right over here. If you see these lines, this means that from the first line up to the third line, that would be your 6-second strip. The reason why this is important is that if it is a 6-second strip, then we can do a technique called the 6-second method. And the way we do this is that we count the number of R's between these 3 lines right here and multiply them by 10. So for this strip, we have 1, 2, 3, 4, 5, 6, and multiply that by 10. That will give us a heart rate of 60 beats per minute. One thing to remember is that this method works best for irregular rhythms. And another tip that I can tell you is that you have to be very, very careful in using the 6-second method. You always have to verify that the strip that you're reading is indeed a 6-second strip. I know some teachers include strips that appear to be 6-second strips, but they're really not. They don't have these 3 lines right here. And students actually mess up the heart rate because they use the 6-second method. This method only works for 6-second strips, okay? Second method that we can use to calculate the heart rate is the big box method. And the way this works is that we divide 300 by the number of big boxes between 2 R's. Our magic number is 300. So for this strip, we are going to use these 2 R's right here. We have 1, 2, 3, 4, 5 big boxes in between R's. And so, using the formula, 300 divided by 5 we have 60 beats per minute. This method works better for regular rhythms only. And this is actually the method that you can use if you don't have a 6-second strip in front of you. And the final step is interpret your strip.
So that is it for today, guys. I hope you find that helpful.
Okay, guys. Hope that can give you a little bit of understanding how to interpret your EKG.
And if you haven't already,
Oops. Okay, gentlemen, I'm trying to go to the next
please hit the
slide.
like.
All right. Okay, did you guys learn something? Maybe not everything, but some, right? Some
Yes.
sort of understanding. Yeah. So this is a good thing when you're going to clinics and you're preparing for your NCLEX, and actually when you're on the floor. Well, you need to know this. So I just thought to put it in so that you at least have some basic understanding. Okay. We talked about these parts, so I'm going to move forward. Now, let's talk about the drugs, okay? The drugs which are used for dysrhythmia, okay? Dysrhythmia. So they are classified, and I want you to know this picture, okay? So know the information on it. Only one thing missing here is class 2. Class 2, and just write it with your hand. Class 2 are your beta blockers. That's one is not listed here. Everything else is class 1, 2, 3, and 4. So class 1 further divides into 1A, 1B, and 1C. And then class 2, then class 3, and finally class 4. These are the drugs used commonly for dysrhythmia, okay? Now, if somebody just throws a name, how would you know which one is class 1, 2, 3, 4, and even within A1, is it class 1A or 1B or 1C? Well, this is what is going to help you to identify. You can use this mnemonic or create your own. Okay, I used to create my own, whatever kind of I'm comfortable with, or I can remember easily. Okay, so all you need here is P, Q, and D, or PDQ for 1A. That will tell you that class 1A drug, which one are those? From P, at the bottom, look, procainamide. For D, disopyramide. And for Q, quinidine. So PDQ, procainamide, disopyramide, quinidine, these are the 3 drugs commonly used, which are your 1A. Then 1B. Now pick up LM or ML, milliliter, right? M for maxillatine, L for lidocaine. Then 1C, FP, PF, whatever you want to use first, flecainide and propafenone. Then class 2, as I said, these are your beta blockers, the drugs ending in LOL, right? Then class 3. Class 3 is your that ADSID, okay? Ads ID or ID ads, whatever you want to use. A, amiodarone, D, dronabinol, sotalol, ibutylide, dofetilide. These are the drugs under that category. And finally, class 4, DV, okay, that's diltiazem and verapamil. These are those 2 beta blockers, which are different than all others who do not end in LOL. Okay, so this picture will help you to identify if you ever need to, from their name, that what class they belong to. Okay, now
Sorry,
moving forward. Huh?
did you say that number 2 is just beta blockers?
Beta
Or am I missing?
blockers. Yeah. On the top, like here, mnemonic, there's no mnemonic for class 2 drugs. That's why it's listed here, though, at the bottom, but it's just not listed on the top.
Oh, I see.
Yeah,
Okay, thank you.
you're welcome. Now, moving further, excuse me, how do these things work? Now, for example, class 1A. 1A. So here, you should have that the previous picture right in front of you to ask, oh, which one were they? Say it says PQD or PDQ, whatever it is, and that will tell you the name. This is how you memorize. You should have that picture right in front of you when you study. So these are antihistaminic drugs in 1A, which are called sodium channel blockers. Sodium channel blockers. So the names are there. As it says, they block the sodium channels during the phase 0 of the cardiac action potential. Now, what does it do? It leads to a moderate level of slowing of the rate of depolarization and resulting in prolonged QRS complex and QT interval on the EKG strip. Okay. Now, once you increase the refractory period of the cardiac cells, these class A1 drugs, they help to prevent that arrhythmia and then maintain the normal rhythm. Okay. So somebody asks you what they are. Well, they are sodium channel blockers. They're sodium channel blockers. Then what else they used for? What I'm not what else they use. What else is important? That is what they are used for. For example, your AFib, your premature atrial contraction, premature ventricular contraction, and those sort of things. These are used. Now, let me go over some important drugs. And within those drugs, what is important for you to know? First drug, procainamide. This is class 1A. We just saw in the previous slide, they're used for atrial and ventricular tachydysrhythmia when the heart is beating too fast. Okay, heart is beating too fast. It could be originating from atrium, could be from ventricular. Now, important
Excuse me,
to know.
Professor. I have a question. On the previous slide, it says increase APD. What's APD?
That is that action potential duration.
Okay.
Remember previously we talked about action potential. So how long that lasts for, that is the duration of that phase. That is called action APD. Okay, going back to other things important. Yes, Cherry, that's fine. These not common, but there's a risk. Too much of it can prolong the QT interval, and that's not good either. Okay, so when you're giving these drugs, monitor patients' EKG. Okay, monitor patients' heart rhythm, how it's going, because it can prolong it, and that's not good. That is one thing you need to worry about. Forget about diarrhea. I'm not worried about that. This quinidine. Quinidine is a cinchona alkaloid driven from a plant. Overdose of this drug, it can cause harm to the ear. Hearing can be impacted. It's called synchronism, tinnitus, ringing in the ears, loss of hearing. They can't hear well, blurry vision, and can also cause photosensitivity. So if patient is taking it, tell them to apply like a sunscreen or something when they go out. And that applies to class 3 drugs as well. But main concern with this drug, ears, toxicity, that is real important. And these drugs has a black box warning for Tortades de pointus. That's also about an abnormality in the heart rhythm. So if somebody has that issue, they should not be taking it.
Professor?
Mm-hmm.
For procainamide, you said that the significant adverse effect was what again? I think I missed it.
The prolongation of the
the
QT
prolonging.
interval.
Okay.
Prolongation of the QT interval.
Thank you.
That becomes extended. Okay. Now, here, class 1B. Okay. 1B, example, like your phenytoin, lidocaine. Now, what they are also sodium channel blockers. Sodium channel blockers. Now, few things what we need to know. For example, for lidocaine, we need to know what it is used for. It's used for ventricular dysrhythmias. Okay, ventricular dysrhythmia. There's one more thing I want you to know about lidocaine. Lidocaine, an adverse effect, which could be dangerous to your patient, is convulsions. Convulsions. That is something real important for us to know. Okay, and I believe it should be, yeah, right here. So lidocaine can cause convulsions. So that's something we need to keep an eye on. And why does that happen? If the dose reaches toxic level, too much of it. Then next thing important about lidocaine, how does it work? How does it help? How does it prevent dysrhythmia? It delays the conduction in the heart and then reduces the automaticity of the heart tissue, like automatically how it beats. So it kind of delays that and try to normalize it. Okay, if it's like premature, beating fast, so it kind of slows it down. When the conduction, the signal slows down, the contraction slows down, and then it just kind of gets closer to the normal rhythm. Another thing normal about lidocaine, equally important. Lidocaine requires a healthy liver to be metabolized. It needs to metabolize. Liver is the organ. Usually, I mean, liver is the most common one. But here the problem is if it's not healthy, what you need to do is you need to reduce the dose of lidocaine at least by 50%. Somebody has a liver failure, liver is not fully functional, they have a liver cirrhosis, be cautious. And the first thing you would do, reduce the dose at least by 50%. These are the important points what you need to know about lidocaine, nothing else. Okay. Now, going further to your class 1C. 1C, okay? 1C, your flecainide, propofenol. Once again, same way they work. They are also sodium channel blockers. Nothing different, nothing different, nothing different. I don't want you to focus on much about these, okay? But just know what class they are in and how they work. Then here comes your class 2 drugs, beta blockers. How do we know they're beta blockers? Well, they end in LOL. Nothing else is going to change. Remember, we don't give it to patients who has asthma COPD. It can mask signs and symptoms of hypoglycemia. You have to be careful in diabetic patients. Same thing. Nothing is going to change. Okay? And how do they work here? They kind of reduce the effect of your, adrenaline, noradrenaline, those chemicals which pace up the heart. Okay, at adrenergic receptors. So they decrease the heart rate, they decrease the myocardial contractility, they also slow down the conduction, and that's how they help your patient. Next is class 3. Class 3. And amiodarone is one of the most important drugs. They ask question on this a lot of times, okay? Now, first of all, what is important? Number one point is, which patients do we use it? So please note this down, that amiodarone, brand name Cardarone, is a drug of choice for ventricular dysrhythmia. Okay, ventricular dysrhythmia. Specifically, if you look at the bottom, it says life-threatening ventricular tachycardia. Now, dysrhythmia we talked about, it could be fast, it could be slow. So here it's tachy means fast, originating from ventricular. So ventricular, the problem in the ventricular, too fast. And that's what the primary indication is for. So that is a drug of choice for ventricular dysrhythmia, could be for AFib and flutter as well. Very specific about ventricular dysrhythmia or ventricular tachycardia, the other name. Everybody clear?
Can you repeat that, please?
Yeah. So amiodarone, as I say, like for every drug, when I tell you what is important, so those are the things which you need to keep in mind. And for amiodarone, important to know is which patient population or patients with what condition this drug is used. So this drug is a drug of choice given to patients who are experiencing condition called ventricular tachycardia or ventricular dysrhythmia, we call it. Okay, that is important. More stubborn. These are more stubborn, dysrhythmias. Now, second thing important about this drug, how does it help in the problem we are trying to resolve? How does it do? Well, that simply means they're asking you, hey, do you know the mechanism of action? So let's talk about that. Now, this drug or these drugs under this class, they prolong the action potential again. And what was that? A rapid rise and subsequent fall in the voltage, the current, the membrane potential across the cellular membrane in a certain pattern. We know that a sufficient amount of current is required to initiate the voltage response in the cell membrane. And if the current is not sufficient to depolarize the membrane, the action potential will not fire. And there's nothing happening after that.
Professor,
Mhm.
can you reiterate that after they prolong the action potential? I got lost there.
Yeah. So abnormality is in the action potential. It's more like a signal, electrical signal going, right? And that was going too fast, correct? Do you know, you understand the problem, right? Tachycardia, going too fast. How does it go fast? It's contracting fast. And what makes it? The signal. The signal is telling from the nodes, beat, 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 contract, 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 right? Now it prolongs the action potential, which sends the signal to beat, 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 faster, faster, faster. Now you delayed it, less signals going slowly. Now the beating is going slow. Problem solved. You understand now?
Yes.
Okay.
Thank you.
That's what happened. It just, as I always say, and thank you for asking the question. That's what all of you to kind of understand it. Understand the problem. Don't just try to cram it. You're not going to be able to keep it with you. Slip out of your mind. Know the problem, what's going on. We know that tachycardia, where ventricular contract, that's what pushing the blood out, going too fast. And who makes it beat faster? Well, signal coming from the nodes. Well, hey, this drug will slow down the signal, will eventually slow down the contraction. That's what the problem is. So know the whole chain of events. Okay. Abudilide, I just put it on there, nothing much to worry about, okay? I just wanted to kind of, I like to put pictures and names. You never know, like when you come across a patient, what they are taking. I try to put the most common ones, but there's sometimes you see like, oh, I never heard about it. Now, class 4. Class 4, they're your calcium channel blockers, CCBs. CCBs. Same drugs, right? We saw previously in your hypertension chapter, like here, example, your diltiazem. Remember those two drugs, diltiazem and rapamycin? So this is one of those. Now, what is important to know? Exactly what is highlighted and what it's used for. This drug is indicated for a specific condition, which is what? Ventricular problem. And if one is AFib, atrial fibrillation, a flutter, and PSVT. What is PSVT? It's paroxysmal supraventricular tachycardia. The problem means fast beat arising from where? Supraventricular position means above the ventricle, over the ventricle. So this is what it's used for. So please know that AFib or flutter, and then PSVT. That's the only thing I want you to know about this drug for this chapter. For some other condition, it could be a different story, but for this chapter. Okay, any questions so far, guys? Anything?
Is PSVT the same thing? What is PSVT?
Okay, paroxysmal supraventricular tachycardia, or simply you can just say like supraventricular tachycardia.
Okay.
Tachycardia, fast beat. Where? Supraventricular. Ventriculars and supra means above the ventricles.
Okay, thank you.
Yeah. These terms, when we do not bring, remember guys, when something complex, something stronger, break it in parts, break it apart, simplify it. Now, when paroxysmal supraventricular tachycardia, like, what the hell is this? Right? Now break it down and it will become simple. We know tachy is fast, cardia means heart. Heart is beating fast. Why? And where? In ventriculars, arising from where? The position called supra, that is above the ventricle. That's where the problem is coming from. Okay. Anytime you don't understand these, maybe hey, just Google it, ask, check, and understand what it is. Then it will stick to your mind better. Now, anytime, remember, I always say, expect the unexpected. Now, expected is what? Somebody's heart rhythm is not normal. You're trying to fix it, and now the rhythm is normal. That's expected. But always remember, unexpected can happen as well. All these antidysrhythmic can make the dysrhythmia even worse. What if you gave a little bit too much? Now it's worse, but on the other side. Okay, because it's going to alter the rhythm one way or another. So just be careful. Not worried about that. Okay, this is another thing I want you to know. Adenosine. Adenosine, what is important? Number one, this drug is used for, once again, same the PSVT, paroxysmal supraventricular tachycardia. Okay, rapid heart rate originating above the ventricles. This drug is only given as an IV push, real quick, not IV infusion, right? You know the difference between IV push and infusion? Infusion runs over a period of time. IV push is pushed once, done. Okay? One push. So given as an IV push, and this has a very, very short half-life. It stays in the body for just a short period of time. After 10 seconds, the effect is gone. Okay? The effect is gone after 10 seconds. Why do we use it? And what is the significance of that 10-second part? Why do we need it like for short period? If it's effective, why not for longer period? Right? There is a reason. Now, let's start from the beginning, where the problem. Now, what is the problem? Dysrhythmia, right? Heart's rhythm is not normal. That's the problem. Now, how this fixes, okay, what happens or what you do when your computer starts glitching? What do you do?
Shut it down and restart it.
You reboot it, right? You're like, It shuts you down. Hey, start over again. And usually, whatever those glitches, it was slowing down, freezing, whatever it was doing, it gets fixed, right? Exactly same mechanism we are applying here. What this does is, it lasts for 10 seconds. And as you give a push, remember this thing, guys. What you're going to see on the monitor, you're going to see a flat line. Don't freak out. Oh my goodness. Did I kill the patient? No. You did a reset of their heart rhythm for just seconds, maybe 2, 3 seconds, 2 seconds, 3 seconds. It's going to flat and then it will most likely fix the rhythm to normal. You just press the reset button. Does it make sense? This is how it works. So that, and remember why I'm telling you this, because this is something unusual. The other drug doesn't cause it. So you need to know. This is different. Important to know. How would you react if you are giving that medication, IV push, and you see a flat line and you don't know? Right? So that's why I'm just putting it here so that you're aware about that. Okay? And we don't want to keep the line flat. That's why we're using this short acting that it's gone out after 10 seconds. Now, you can't make the line flat anymore. Harjot, do you have a question? Or was accident?
Yes. What sort of situation may cause you to give this drug?
Like, so as you said, the severe, like supraventricular tachycardia, that the patient heart, that ventricles are contracting real high pace, real high pace, and that is a high risk. The patient can have cardiac arrest and all that, stroke or anything severe. And this is not giving in like a clinic or you're going to give it somewhere else. So this is in the hospital setting, emergency situation. Okay. All right, let's move on. Nursing implication, very basic, guys. Any drug requires you to first assess, know what other conditions they have, what medications they are taking, either it's an OTC, prescription, herbal medications, supplements, what their usual diet is, everything. Do they smoke? Do they drink? Do they have any stress at work, home, whatever it is? Get that information. Be nosy. Okay? Be nosy. Just ask everything as much as you can, because that's the right approach to know, right intervention, and being prepared. What can happen? Okay? Um, Now, because these drugs, where are they going to act? On the heart rhythm. So what are we going to monitor? The heart, right? The heart rhythm, heart rate, blood pressure, that's what will be altered. So this is the very, very, very basic thing that we're going to monitor where the problem is, and we're expecting a change. So we monitor all those factors, the variables, right? And because these drugs are important, it's one of the most important organ in the body. And if they skip a dose, could be a problem for them. Tell them take it at the same time every single day. Do not skip or do not double dose. And if it's an extended release, sustained release, controlled release, whatever it is, do not ever chew it. Do not ever crush it. That is called dose dumping. Okay, and always monitor the EKG. Okay, and now tell the patient signs and symptoms of what? Problem, indicators of problem. This is about heart, right? Any problems with heart, we need to monitor. For example, shortness of breath, right? Remember we were talking yesterday why that happened? Left side heart failure, fluid backing up in the lungs, problem. Breathing, crackles, when you listen to lung sounds, fatigue, all that. Edema, right? side of heart failure, fluid backup in the extremities. All those things are important so that your patient understand that, hey, if I'm experiencing this, I was told about that, or that could be a problem. I need to call. Okay. Now, these drugs, such as we talked about yesterday as well, like your digoxin, take a full 1 minute pulse, full 1 minute, not for 30 seconds, multiple objective, full 1 second. And once again, super nurse duty. If it's below 60 or above 100, you will hold the dose and call the doctor, right? That's what we do. Okay, any questions so far? And we'll be taking a break shortly, okay? Any question? No? Okay. Now, as a super nurse, once again, extra burden on your shoulders to monitor therapeutic effect and adverse effect. Adverse effect, we just saw an example that indications of problem, right? Edema, shortness of breath. That's something new, or adverse effect, more specifically, we talk about something unexpected, unusual, which you're not expecting from that drug. Therapeutic effect would be that their normal rhythm, BP is normal, their, the pulse rate normal, edema is going down, they're not tired anymore, or at least less tired, right? So those sort of indicators are pointing towards therapeutic effect of the drug. Okay. So are you guys ready to take a break? Yes?
Yes.
Who said no? No?
I said yes.
I said yeah. See now, clarification right away, like, right? Okay, guys. Yes, so it's 10:22. We'll be back in 10 minutes at 10:32, okay? And we'll continue. Thank you.
Professor, can we try one of those questions at the end of this chapter?
Okay. Let me see. Okay, let's see if you remember that. Remember lidocaine, what I told you? The correct answer is D. They're sodium channel blockers. So they're used for, remember that I told you PSVT, that's what the ventricular dysrhythmia is. Ventricular tachycardia, they may write that down. But D is the correct answer. Okay. Okay. Let's see if you remember this.
B.
B?
Yes.
Yeah, that is correct. Remember that short half-life, 10 seconds? Okay, yeah, so let's keep it like that, take a break, and
you.
come back. We'll continue. You're welcome.
Professor, I didn't get to sign in earlier.
All right, let me see. Okay. Okay. Okay, what time did you come in?
I came in 9:20.
9:20. Did you send a message there in the chat? Did you write it down?
No, I did not.
Why not? Always, if I mean you're late, either speak up or just message and make sure that I get that. Okay?
Okay.
Yeah. Okay. I got you.
Okay, thank you.
Mhm.
Professor, I've just joined for my laptop. I'm in the waiting room. Can you please let me in?
Hold on. Let me see. I'm sorry. Who was that again? Rabia?
Yes.
Rabia, it doesn't show me anything that anybody's waiting anywhere because I didn't even kind of activated that part.
Oh, maybe I used the wrong link. I'll be right back.
Maybe.
All right.
Okay. Okay. Excuse me. Okay, welcome back, guys. Sorry for a couple of minutes delay. Okay, let's turn the cameras on so we can move on. Excuse me. All right. Okay, so next chapter is your coagulation modifier drugs. Now it's written as coagulation modifier because we're gonna cover them more broadly. It's not about anticoagulant. Okay, that's why it's written in this way. So we'll talk about what conditions and the medications and important things about those medications, including their mechanism of action, indications they're used, any contraindication. Remember, these drugs are high-risk drugs. Okay, these drugs are high-risk drugs, so you have to be very careful. The patient would be a high risk of either developing a clot or bleeding. Okay, so you have to be real careful about that. So those are going to be important points, whether you're educating your patient, you're monitoring your patient, you're developing a care plan. Those are extremely important. Now, first of all, when we talk about coagulation, talk about modifiers, so let's know first what that is. Okay, what that is. Hemostasis. Now, heme means blood. Stasis means something getting stationary or stopped. So the process of stopping the bleeding is called hemostasis. Everybody is clear about that term? Yes? Heme is blood. Stasis means static, something stop now. So stopping the bleeding. Okay? Excuse me. So physiologically, that this is process which stops the bleeding at the site of injury, right? So whenever somebody gets injured, what happens? The body acts, right? The body acts to plug that so that they don't keep bleeding. It's a crucial mechanism. Otherwise, the blood loss will keep going on. Very dangerous. Then it's a very well coordinated interaction between the vascular system, the platelets, the coagulation factors. There are different phases, usually like 3 phases. You see my screen, right? I hope I didn't stop sharing the screen. Okay. Now, vascular spasm, or you can call vasoconstriction. So as soon as there is an injury, right, to blood vessel, the vessel constrict. Why? To reduce the blood flow to that place, constricting it and limiting the blood loss. Okay? After that, platelet plug formation. Body now is going to plug it. The platelets, they adhere to the expose the collagen fibers wherever the vessel is damaged on that wall and become activated. These activated platelets, they release chemicals. Okay, you can also cause signals in a form of chemicals. Okay, now what they do, it's like you're driving on a freeway, right? You're driving on a freeway. Now you just notice that there's an accident, and then one person jumped in, the other said, hey, look, that accident happened. Now the second is looking in there, maybe trying to help, third, fourth, everybody's slowing down. It's kind of getting over there all together in that small space. So these chemicals, signals, they're telling the other platelets, hey, come here, look, something happened here, something happened. They all get together there. It's called platelet aggregation. Okay, platelet aggregation. They go at the site of injury. Okay, now these platelets, now because there are a lot of platelets in a certain area, small space, they start forming a platelet plug, which covers the wherever the damage is in the vessel wall. Okay, and then finally the coagulation, the blood clot forms. So the platelet plug is then reinforced by the stable blood clot through a process which is called coagulation cascade. Why? Because one activation go and now activates the other one. That activates another. That activates another. So that's why it's called cascade. It involves a series of enzymatic reaction, which leads to the formation of strands of the fibrin, the clot. Okay. Now these strands, they weave through the platelet plug and makes it more solid, so that there's no leak. There are different pathways involved in that, intrinsic and extrinsic, inner and out. Okay, so excuse me. Then other thing, what I want you to know here is, see the two terms here, one is thrombus and one is embolus. Thrombus is simply means a blood clot, anyway, a blood clot. But when that blood clot decides, I'm gonna go on a walk. All right, I'm gonna go on a walk. It starts moving in the blood vessel. That moving mobile thrombus or clot is now called embolus. Okay, clear? Everybody understood? Thrombus is simply a clot, and that clot, when it starts moving in the vessel, called embolus. And that gentleman, now it's on their mood wherever it decides to take a break or sit down, settle down. And wherever it settles down, that's where it creates the problem. And that's how these problems are named. Okay? For example, if decide to go down in the legs, right? Clogs there, blocking the blood supply, called DVT, deep vein thrombosis. If travels to the brain, what happens? Stroke, right? Goes to lungs, pulmonary embolism. Goes to heart attack, myocardial infarction. So wherever it goes, that is the reason that when that happens, there are interventions required, possible either to dissolve that clot so that it does not go and block somewhere, or take it out. This is how the mesh is formed, and whenever there's a damage, it tries to plug. As I just mentioned, when it starts traveling, right? So wherever it decide to stop, wherever gets stuck, and if it's in a coronary artery, heart attack, myocardial infarction. In the brain, stroke. In pulmonary circulation, pulmonary emboli. Going down in the leg, deep vein thrombosis. Okay. All right. Now, I do have I believe, like 3 videos. I won't be playing it because they're long, but I want you to watch those videos. That will make it a little bit easier for you to understand that how the cascade I'm talking about, how after the injury, what happens, how platelet comes and uh, plug that injured wall or the vessel. So those are helpful. I want you to please watch those videos, but they're lengthy, so I don't want to kind of play them here. This we talked about. Okay, now there's a system called fibrinolytic. Okay, fibrinolytic. Fibrin, we know the clot. Lytic or lysis means breaking down something. Now, what they break down? The clot. Okay, so this is body's natural mechanism for breaking down the blood clots, right? Once they fulfill their purpose of stopping the bleeding. Remember the clot formation? But the body makes sure that dissolves the rest. Once their job is done, it tells them you're done, guys. Okay, it breaks them down afterwards so that they don't cause problem in the body. Otherwise, what if some of them they start giving trouble? Yes, Zara, question?
Does this system only apply to the heart, or could it also apply to people who have those deep veins in their legs that have blood clots there?
Okay. Now, the system, it works in your whole body. No matter where the injury is, not only in the heart, wherever the injury is, that's where body plugs the leakage, and then that fibrinolytic system breaks down once the platelets jobs, or you say that the blood clots, the fibrin, when job done, then it kind of dissolve them, break them down anywhere. Okay. Now, what are the key components of that? Okay, like your plasminogen. Plasminogen, it keeps circulating. It's a circulating inactive precursor. It's a protein which gets converted into plasmin, which is an enzyme which is responsible or breaks down the clot. Okay, and it gets incorporated into when the clots are forming. Isn't it how wonderful, amazing the body is, right? You're just putting things in there. Let them do what they're supposed to do, and then they dissolve it. And then plasmin. Plasmin, as we just talked about, that's an active enzyme which degrades the fibrin, and we just saw that it gets converted from your plasminogen. And then there are plasminogen activators. These are the enzymes which convert, plasminogen to plasmin, which eventually break down the clot, right? Okay. We talked about that. Now, let's talk about a genetic disorder called hemophilia. Now, what is that? It's a genetic disorder, as I said, okay, where patients are deficient of specific clotting factors, those factors which are responsible to form a clot. Now, if they're deficient, what's going to happen? When they get injured, they do not have those clotting factors which were going to or supposed to help stop the bleeding, correct? The result, they can keep bleeding. So it is a highly risky condition. This patient can bleed to death. You got to be very careful with these patients. And they should have like identification alert bands or bracelets, whatever, so that if they ever kind of get involved in accident or anything, the crew, emergency crew, they know that this patient is high risk of bleeding. Okay. So there's a deficiency in those clotting factors. Usually, your clotting factor, your 7, 8, 9, those are the clotting factors which are deficient. Zara, you have another question?
So you're saying that these patients, that even if they get a paper cut, they could bleed to death?
Not to paper cut, but they will bleed longer. But in case of severe injury, they're at a very high risk. Okay. So this is how it looks like. For example, normal blood vessel, right? It gets injured. Now it starts bleeding. Generally, the fibrin, the clot forms with the help of all those clotting factors. But in case of hemophilia patient, it just can't form the plug and just keep bleeding. Okay. And as I mentioned in the beginning itself, the very first slide when we're starting this chapter, these are high risk drugs. Make sure you monitor your patient, educate them properly so that you're not missing an important point. You can put them at high risk. Now let's talk about these drugs one by one. Number one, like anticoagulants. Anti, which are up against who? Coagulants, coagulation. So simply, they prevent the thrombus formation, the clot formation, but they do not dissolve an existing one. So somebody asks you, do they prevent or they dissolve? They prevent the formation of clot. So that is important to know, to differentiate which drugs prevent the formation of clot, which drugs are used to dissolve a previously formed clot. All right. Okay. Now, excuse me. Antiplatelets. So they prevent the platelets from clumping, like getting together and forming a clot. They keep them spread out. Remember, I was telling you when there's an injury, the platelets kind of send signals to all, say, hey, look what's going on. They get together, aggregate. So these drugs keep them spread out. Okay. Okay. Okay, now the drugs called hemorrhagic drugs. These drugs, they alter the function of platelets, but at the same time, do not block or prevent the platelets from working. They just change how they work, but it doesn't block them from working. So they also call like blood viscosity reducers, make or blood thinners. That's what they are. They improve the blood flow, right? If the blood is thick, make it thinner, make it less thicker so that it can flow well. Okay. Like your pentoxifylline, there is cilostazole, and there are a couple prostacyclin analogs like your alloprost, epoprostenol. Those are the drugs falls into this category. Then next are your thrombolytics. Lytics or lysis means breaking down. Breaking what? Thrombo means thrombus, who breaks an existing clot. They're not to prevent they break an existing clot. Now, the bottom one, anti-fibrinolytic or hemostatic. Now here, don't get confused. Please pay attention on this one. There are drugs which are thrombolytics, which breaks a clot. These drugs are anti-fibrinolytic. Fibrinolytics what? Who breaks the clot. And they're against. So they prevent the lysis breakdown of the clot. So simply means they promote the formation of a clot, coagulation. Examples, the drugs may be used in hemophilia patients so that, when they're bleeding, you're giving them something to make a clot. Okay. Okay. Now let's go over those classes and we'll go over some drugs and important aspects. Anticoagulants. No, they are against the coagulation, prevent the formation. Correct? Simple words, blood thinners. Now, they could be vitamin K antagonists, such as warfarin, right? Warfarin is a blood thinner, right? Then, your drug thrombin inhibitor, like your Pradaxa, which is dabigatran, that's also oral pill. Then your factor 10A inhibitors, like your Xarelto, Eliquis, those are the drugs falls into that category. Then there are like heparins, right? Like unfractioned heparin, enoxaparin, and all that. Those are low molecular weight heparins. Then there is fondaparinux, which is Rixtra, and then some direct thrombin inhibitors, the parental ones, injectable. Those are like your argetroban, and there are a couple more. Rivaroxaban, there are three called like ART. So they're different ones. So let's go over them one by one. Now, heparin. Heparin number one is it's a very high risk drug. Okay, high risk drug. First point is, how do they work? How do they work? Well, as it's highlighted there, that they inhibit the clotting factor 2A, thrombin, N10A, clotting factor, who help in formation of clot. So you block the helper, you're blocking the clot. Okay? And these can be used for prevention as well as for treatment of blood clots. So they kind of increase the activity of your antithrombin, which is an inhibitor of these coagulation factors we're just talking about, the 2A and 10A. So it just kind of reduces the formation of the clots, the fibrin. Unfractioned heparin, low molecular weight heparins. Heparins are important. You will see these enoxaparin, dalteparin, very commonly used patient post-surgical. Okay, after surgery, such as like hip surgery, knee replacement surgeries, because they're at high risk of developing clots at that time. They went through a major surgery, high risk of developing clots. So these medications very commonly used during that. Okay. Now, these drugs prevent or treat the clot. Could you tell me what is the biggest risk if the patient is on this medication? What is your biggest concern?
Bleeding out.
Bleeding. Yeah,
Bleeding. Remember, we are giving something to prevent or treat the clot. It's gonna thin the blood. Well, the patient now is at the risk of completely opposite thing. Rather than clot, there might be a risk of, excuse me, bleeding. Very good. Good job. Okay. Now,
Professor,
mhm.
at risk of bleeding internally, or is it when they have like an external injury?
It could be both.
Okay.
It could be both. Yeah. Internally, without injury, if there's injury, could be external. Okay. Now, heparin, it comes in various strengths, okay? Various strengths. And as I said, very, 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 very important to look at, double check the dosage, the strength of the medication. Okay, a small error in dosing can put your patient at extremely high risk of bleeding. Okay, highly diluted with less number of units, those are usually given to keep the catheter open, like infusions. You know how they get clogged with blood clots? So to flush the catheter, but remember that's highly diluted. If you accidentally give highly concentrated, the patient will bleed. Okay. Now, as I just told you, these are high risk drugs for what? Bleeding. Well, whenever there is a high risk, what we do? We monitor our patient, right? We monitor our patient. So the goal is that we should not give them too much of it. Well, how would we know? Some sort of lab testing, right? Which tells us that it's within that desired range. So extremely important to know the lab test performed. Anybody knows which lab do you monitor?
The
Prothrombin time.
Yeah, APTT, activated partial thromboplastin time. APTT. Okay, please know that. Very important. Now, which lab to monitor with heparin? It's APTT. Okay. This is how your low molecular weight heparin looks like. For example, here Lovinox. These are pre-filled syringes. Very commonly, this is one of the most common ones used, and this is dalteparin, but this is what you see very commonly. Uh, the pre-filled syringes. Now, usually what we do is when you pull the drug, right, before giving injection, if you see like a little tiny air bubble, you kind of tap on it and try to expel it, right? That's very common. With these drugs, as I said, small alteration in the dosage can put your patient at risk of either clot or bleeding. If you lose the drug while you're trying to expel the bubble out, you may lose the drug. Now, patient might be at risk of clotting. Okay, so do not try to expel the air bubble out of it. It's not going to do anything back to your patient. All right, that's important point. Do not try to expel the air bubble out from the syringes for this medication. Okay, now, once again, as I said, it can be used for prophylaxis to prevent as well as for treatment. Okay, now, very important to educate your patient, and if they're under your care, to monitor the signs of symptoms of the biggest risk associated, which was bleeding, right? So these are the signs and symptoms, right? Hematuria. Heme means blood. Urea means urine. Blood in the urine. Hematuria. So if there is blood in the urine, what is that? Sign of bleeding. Right? Agree? Now, melena. Blood in the stool. There's fresh blood in the stool. Problem. Okay. It's a dark color stool. Petechia. That is like little tiny dots, red dots under the skin over the body. That is an indicator bleeding under the skin. Little tiny dots over the skin. I'm not over the skin, I'm sorry, under the skin. You will see the little tiny dots. Okay. Now, if that happens, what you're going to do? Well, patient is at risk of bleeding because of the drug, correct? So first thing to do is do not give them more. Stop and call the doctor. Agree with me on that, right? We're not gonna hurt them more, and we're gonna call the doctor to see what we can do. And what we can do is about, here comes the antidote. Probably gonna get an order of an antidote. Now, what is the antidote? Now, one thing you may find out, there are like 2-3 different antidotes here in this chapter. And probably by tomorrow, day after tomorrow, they will mix up. Which one was for heparin, which one was for warfarin, this and that. So let me tell you how to remember. Okay. Heparin starts with what? H, correct? Heparin starts with H. Protamine starts with P, correct? Now you guys are kind of, tech generation who likes Apple, right? Mine, like, we're old generation. Like since, I don't know from how long and still at present, I'm using another popular brand of computers, HP, Hewlett Packard, right? You guys heard HP brand of computer, right? So just remember the computer brand HP. That will tell you that for heparin, antidote is protamine. So now can mix. Okay, understood? If you don't like mine, create your own, guys. Okay, that's up to you. But I'm just giving what I memorized that HP. Now let's move forward. Okay. Now remember heparin, what it does. Prevent or treat the clots, right? So patient might be risk of bleeding if there's too much of heparin. The condition is called HIT, H-I-T, which is heparin-induced thrombocytopenia. Okay, thrombocytopenia. Penia means less. Less. So thrombocytes goes down, which puts your patient at risk of bleeding. So that is one condition to consider that your patient might be at risk of, right? Thrombocytes, you all know, right? Platelets. And platelets are the one responsible for forming the clots, right? Fibrin. Okay, any questions so far? All good? Everybody awake? Okay. Now, here comes the coumarins. Have you ever heard about coumarins? It's simply the class for warfarin. Okay, the warfarin, its class is coumarin. Have you ever heard before or no? Coumarin. Alfred, yes. Some yes, some no. Okay. Yeah.
Coumadin, but not coumarin.
Yeah, coumarin is a brand name. The coumarins is just a classification it's under. So coumadin is the brand name, warfarin is the generic. Now, once again, this is a high risk drug as well. For what? Bleeding, correct? bleeding. So first it's how does it work, right? How does it work? Well, it inhibits the vitamin K dependent clotting factors, factor 2, 7, 9, and 10. You're blocking those factors. Okay. Excuse me. Next thing. Remember in heparin, we knew it's a high risk drug, so we monitored a lab called APTT, correct? So this is also high risk. So we need to monitor a lab here as well, PTINR, right? Or thrombin or international normalized ratio, PTINR. Yes, that's what we need to monitor here. So now
Can you repeat that, please?
Yeah, the lab value to monitor is PTINR. You may see somewhere just the INR, somewhere you see PT/INR, same thing, okay? But it's different than your APTT, that's different. So PTINR. If the patient is not taking warfarin, usually that value is around 1 or below 1, okay? Now, if your patient is on warfarin, the value normally it should be between 2 to 3. And certain resources you file in 2 to 3, some may say 2 to 3.5. I usually go with what NCLEX expect you to follow, and that usually is between 2 to 3. Okay, now what is the significance of this value? Number one, it's a narrow therapeutic index drug. So add warfarin to the list of medication which are narrow therapeutic value or index. Why? Because if the lower value is 2, the higher is 3. So between 2 and 3, that's what we need to prevent the clot. If the value goes below 2, patient at risk of clot formation. If the level goes above 3, the patient is at risk of bleeding. And that's why we monitor. And the lab is PTINR. Okay, is that understood? Everybody is clear? Okay, now we know that this tablet, this drug, is used for a purpose. Now assume a patient was in hospital for surgery, right? And just say like hip surgery, right? Hip surgery or knee replacement surgery. Remember enoxaparin, that heparin, low molecular weight heparin I was telling you, it's a very commonly used drug to prevent the clot formation after surgeries. So now that patient is now getting discharged to either, you can say they're going to a rehab, or they're getting discharged from there as well, going home. In that situation, you may find the patient is on heparin, as well as you just noticed that the doctor gave a prescription of warfarin. You're like, what are you doing? The patient can bleed. Why are you giving both together? Or the patient says, hey, I was in heparin. Why are you giving me this? Or if you're going to give me warfarin, it's the same thing. Why are you giving me heparin? Well, that is very important to know. It's called overlap. Why it's done? Because warfarin will take about 5 days or so to build up in patient's system in enough amount to prevent the clot formation. But we need to keep the patient safe for those 5 days too. So we overlap heparin for 5 days, maybe reduce the dose slowly, but we still overlap it for those 5 days until enough warfarin builds up in the body to prevent the clot formation, keeping the patient safe from that clot. So you will see this overlapping of both medication. Does that make sense? Yes. That's an important point. You will see this coming.
Professor,
Mhm.
just to make sure I got it right. So warfarin is the one that takes 5 days. So then you give
Yes,
heparin during that 5 days to okay.
warfarin,
Warfarin is
because
the one that takes longer.
those
Okay.
patients post surgery, they were already on heparin. Heparin is which will be discontinued, right, first, and they will continue on warfarin for maybe longer, based on the risk factors. But the warfarin, from the day it's taken first, it started, it will take 5 days to build up in the system in enough amount to do what the heparin was doing to prevent the clot.
Okay, thank you.
Understood? Okay, you're welcome. Alrighty. What else? What else? What else? Anything else? No, that's pretty much it. Okay. I'm gonna come on something else. Now, what conditions it can be used for? So this is either to prevent or treat clot, right? So for example, this is like deep vein thrombosis, like when the clot formed and traveled to the leg, right? Got stuck there. If it traveled to the lungs, pulmonary embolism. Well, if to the brain, can cause stroke, right? To prevent that. In the heart, can cause myocardial infarction or heart attack, to prevent that. So these are conditions or diseases which we can prevent by using this. Now, because this is a high risk drug, now what is the biggest concern? Bleeding, right? Bleeding. So we monitor once again the same signs and symptoms of bleeding. Correct? Now, what if it happens? What if it happens? Well, we need an antidote. Similar way, we need it for heparin. We use protamine. Now here, it's vitamin K. Now I shared that little tiny tool with you, HP, to remember that for heparin, the antidote is protamine. For this, remember weak, WK, weak. Warfarin starts with W, K, vitamin K, weak. So this is an antidote for warfarin. Yes. So these little tiny tips will keep things organized, will help you to answer correctly. Otherwise, they will mix up. Very commonly, it's just a matter of hours or maybe a couple of days, they will mix up if you do not memorize these little tricks. So please know this. Okay. So we know risk is bleeding. If they're bleeding crazy, well, you may need to give an IV infusion of the clotting factors, human plasma. You may have to give, blood, all that, if it's a high risk. Now, moving forward, anticoagulant. These are factor 10A drugs, factor 10A, right? These are very common. These are like more newer ones, like this, your rivaroxaban, Xarelto, your Eliquis, apixaban. These are the most common ones you will see. These are also, but these are more common ones you will see. And as the name says, they inhibit the factor 10A, which is responsible for clotting. So they can be used for prophylaxis. Like here, we're talking about Erixtra, the fondaparinux, which is injectable. So this can be used for prophylaxis, means to prevent and to treat DVT, the deep vein thrombosis in the leg, a clot stuck in the leg, or pulmonary embolism is stuck in the lungs. Okay, once again, the biggest concern is bleeding. Now, this is what I was talking about. Very common drug use, Xarelto, rivaroxaban. This is a factor 10A inhibitor. What do we use it? Once again, it's about clot. So which condition is a result of clot formation, such as stroke, right? So it can prevent stroke, AFib. And as I said, post-operatively, like your patient has a surgery, always they're at a high risk of forming a clot. So it can be used there, and very commonly you see any orthopedic surgeries and two most common hip and knee replacement surgeries. Okay, Shahina, you have a question?
Yeah, so previously you said anticoagulants, so they prevent clot formation, but they do not dissolve existing clots. On the previous slide, that medication, it said that it treats deep vein thrombosis, so I was confused on that.
So there are different types under that umbrella term of anticoagulant because they act at a different place. They act differently. So that is the reason that they can be used for both purposes. One is like, okay, to prevent, maybe they just don't let them settle down, keep them kind of separate, antiplatelets. The other ones, they don't let them coagulate. But here, they are directly acting on the coagulation factor, 10A. So that gives them that ability that they can prevent as well. Because those factors are responsible to form the clot. So remember what I told you that there are like 3 videos there I want you to watch? You watch that video, that will tell you why. Because it's going to show you the coagulation steps, right? And in those steps, you will see these factor 10A, factor 9, factor 8, 7, all stepwise there. And it will point you which drug blocks where. And you will find this drug pointed there blocking that factor 10A. And from there, if you don't block it, the next step is the formation of clot. So you're blocking there. So different drugs, because they act at different phase, different step of the coagulation, they can have different type of effects. It's really hard to generalize some drugs because they have different targets. Okay, but good question though. Okay. This we talked about, inhibit factor 2A, the Pradaxa, dabigatran. Then there's another one, argatroban. This is infusion one. This is used for, heparin-induced thrombocytopenia, or somebody going for PCI. Anybody heard about that? PCI, percutaneous coronary intervention. So it's like somebody maybe, experienced like stroke or something. That's like a clot in the vessel. They brought into emergency department, right? Now, what they do first, how they put the catheter in, they put the camera through, take a look at it, right? And if the vessel is clogged, they put a stent in, or they try to remove the clot. So during that phase, they're at risk of clot formation, even higher, because it's an intervention in the body. It's not something outside. They're putting something in the body. And this drug can be utilized there. Now, this is also a common drug, Pradaxa, brand name, generic dabigatran. Now, about this drug, what you need to know is, as it says, pro-drug. Remember yesterday we talked about pro-drug are in inactive form until the liver metabolizes it and converts that inactive form to active form. Okay, so this drug also requires a healthy liver. Okay. And if somebody's kidneys are not fully functional, they can still take it. You may need to monitor them more, as well as you need to adjust their dosing. You have to reduce the dosing. Now, for this drug, if your patient experiencing toxicity, now what do we give? Antidote. What is the antidote for this drug? Now, this drug is called Prodexa. The antidote called Prex Bind. Okay, generic name is Edarucizumab. Okay, and Shahina is like, oh my goodness, why can't you keep it simple, right? I know, I know what you mean. Okay, uh, I feel so sorry, guys, for you that these days all the drugs are the names are complex. I don't know if they're just out of simple names. Even it's like, you know, something like how we have omeprazole, we have antacid, some drugs, like even those drugs coming up with complex names. When I was in the pharmacy school, there were only two type of drugs which has crazy names, and I was shaking the head just like you. Okay, those were cancer drugs and HIV drugs. I was like, can't you just keep it simple? It looks like they don't want to, right? Just want to give us our time. Okay, so Praxbind is the antidote, okay, for Pradaxa. Okay, gonna move a little quicker. Now here comes contraindications. To who or which patients it's not safe to give. Number one, the biggest risk is bleeding. So patient has risk of bleeding, we don't want to give it to them, correct? Why would we? Pregnancy, warfarin is a no, 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 and no. So make sure you know that as well. No warfarin to pregnant patient. Okay. Now, low molecular weight heparins like your enoxaparin, they are also contraindicated in patients with epidural catheter. Now, this is different. These are not urinary catheter. We're talking about epidural. You guys know what that is, right? Epidural? Epidural catheter. So don't give it to those patients. Okay, so once again, biggest concern, guys, to monitor bleeding, 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 and bleeding. Any signs of bleeding, that's what we are looking for. I'm not worried about here. Okay, here comes the antiplatelet. Very common drug, right? So they prevent getting platelets close to each other at the site of injury, right? Then that's a problem. So they keep them spread out. One of the most common example, aspirin, okay? So attach certain drugs with each class. Aspirin, number one on this one. Number two is clopidogrel, Plavix. Okay, usually aspirin, 81 milligram, call baby aspirin once a day. Clopidogrel, usually 75 milligram, 1 POQD, that's what it's given, okay? Then there are others. Prasugrel, which is Effient, and then there's some injectable as well, like your RioPro, which is your Epciximab. So they prevent the blood cells called the platelets from getting together and forming a clot. Okay, they used to prevent, or if somebody already has a cardiovascular disease, have stroke, heart attack, so future complications, these medication can be used. As you see, aspirin given to prevent or who already has it, so they do not experience again, aspirin is given, right? So that's your antiplatelet drug. Here is your aspirin. Now, what is important to know about aspirin? What they can test you on? Number one, aspirin, if it's an enteric coated, do not chew it, do not crush it. Please do not consider it as just basic point that everybody knows it. No, it's important. They test you on this because it's an important educational point. Okay, make sure You do that. Number 2, educate your patient that please know this. Even though we call it baby aspirin, it's not that simple. Even that baby can put you at risk of bleeding. Okay, so know that. Next, whenever they are taking aspirin, make sure they're drinking enough water. It can cause GI upset. And if it does, they can even take it with food. So at least 6 to 8 ounces of water. And if it still upset the stomach, take it with food. Now, one more thing, and these are all important, okay? These are all important. Do not give a salicylate, which is the classification of aspirin. It falls under that, aspirin. So salicylates, or you can say aspirin, do not give it to children and teenagers who are showing flu-like symptoms. There is a severe condition can develop called Ray's syndrome. Ray's syndrome. Severe condition. So to prevent that, make sure you ask about these symptoms, which the big concern are, so that you can prevent that from happening. And that's all you need to know about the aspirin. Okay, any questions so far? No? Okay. We'll take a break in a little bit. Okay, we have kind of more slides to cover. Okay, now here comes number 2, most commonly used. Clopidogrel comes in 75 milligram, and usually it's 75 milligram 1 QD. This is an ADP inhibitor. ADP, that's adenosine diphosphate inhibitor. Now, what is that? This is a substance which is released from platelets, right? And those platelets then activates the other platelets, and they become closer, form a clot. And when you inhibit that ADP, now you're blocking that activation one from another, that chain reaction. That's how you prevent the clots. Okay? They're called that also P2Y12 inhibitor. Then the other drugs are your prasugrel, your ticagrelor, which is your Brilinta. They're in the same class. They work in the same way. Okay, you will see all of them. Most commonly, you will see clopidogrel because that was manufactured, got in the market at an earlier point. And now generic available for long time. It's cheaper, so insurances prefer that as well. The brands cost them more, so just kind of try to restrict those, but they kind of same effect. Okay, now here comes the drugs called thrombolytics, which breaks the clot. And who can you break? Which is already formed, right? So this is not to prevent, this is to break down an existing clot, right? Thrombolytics. They also called fibrinolytics, right? Or just say clot busting drugs. So they dissolve the blood clot, which are already in the blood vessels. Now, what they do, how they do it? Well, they activate the body's own fibrinolytic system, the system which breaks down the fibrin, the clot. They activate them. Where they're used? They're used in the emergency treat, like acute condition. I'll give you an example, right? I was telling you about art therapy. Why? See the name of the drugs, current drugs. A, altiplase. R, retiplase. T, tenecteplase. Not all together, it's one or other. You will see this. Okay, which conditions? Patients enter the hospital, okay, with what? Maybe they're having a heart attack. maybe they're having stroke, maybe pulmonary embolism, where you need to restore the blood flow. The longer it stays blocked, whatever the areas past that blockage, they will experience ischemia, not enough blood or rich supply of oxygenated blood. The tissue will start dying. So you need to dissolve it quickly. And their timeline set in their, door to needle time, or they say from the first contact from home to um, the needle time. I believe from home it's 3, and then I believe it's 1, or maybe 90 minutes or something from the door to the needle for them to be active. Okay. We know that mechanism of action, that the breakdown, the formed one, by activating the body's own clot breaking mechanism. And these are the condition, as I just mentioned, like somebody's having myocardial infarction, heart attack, stroke, all kind of situation. Now, once again, what is the biggest concern? Well, we are trying to break the clot. The risk is bleeding. Okay, risk is bleeding. So make sure monitoring the patient for bleeding. It could be internal, it could be superficial, it could be intracranial, anywhere. Make sure that is being monitored. Very important. Okay, this is what looks like. Altiplase, see the name, cath flow. Cath labs, that's where used in like cardiac situations, cardiac conditions like, myocardial infarction, heart attack and stuff. That's why it's named. It's TPA, called tissue plasminogen activator, which is body's mechanism of breaking them down. Okay. Here comes the opposite guy, antifibrinolytic, who block the breaking of clot. So it helps or it promotes the formation of clot. And example, your hemophilia patient. Okay? Hemophilia patient, remember, they do not have clotting factors, they can bleed. So those patients, they need something which can promote clotting in certain situations. It's not that they're given all the time. No, in certain situations. That's what I'm talking about. I'm not worried about much. Now, this drug, desmopressin. This drug used in hemophilia, but another important use of this drug, especially, it comes in a nasal spray. Nasal spray. That is used for nighttime bed wetting, when kids pee in the bed nighttime. So nocturnal enuresis, nighttime bed wetting, used there, and also in diabetes insipidus. Remember, it's diabetes insipidus. It's not diabetes mellitus. It's not high blood sugar. It's insipidus. Okay. Next.
Is that drug an sorry, is that an anti fibrinolytic drug?
So this drug has some effect similar to that. It's not that commonly used for that purpose, and that is the reason what I show here is what it's used for. Okay, because they're similar. Hemophilia falls under that category of these blood clotting conditions. So this is used there when you need to promote. So the previous class, what we just talked about, right? So falls under that. But I wanted to add that diabetes insipidus and nocturnal enteritis as well, even though it doesn't belong in this chapter, but they do ask questions about that side of this drug as well. But as what you just mentioned, yes, it belongs to that drug, antifibrinolytic, that it has that action where it promotes, especially for hemophilia patients. Okay.
Thank you.
Yeah. You may not see for more in generalized way for anything else in hemophilia. Okay. Nursing implications as an RN, what factors, points are important for you to not hurt your patient, keeping your patient safe, preventing any injury? Now, knowing what can hurt them. Is there any medication they're taking which has similar effect, can put your patient at risk of either bleeding or clotting? You need to know. Is it safe for them to take it? What lab values you need to look at? Okay, all these things are important. Now, a couple of things I want to add here, which are equally important. Please remember when I was talking about heparin that do not try to expel the air bubble, right? So there's another thing I want to add here. One, there is a specific type or size of the needle you should be using with heparin injection. Okay, so please write this down. 1/2 to 5/8 inch, 1/2 to 5/8 inch, and 25 to 27 gauge. You want me to repeat it? Yes? Okay. So write it again, please. 1/2, okay? Half, simply half. 1/2. 1/2 to 5/8, 5/8 inch, and the gauge should be between 25 to 27. Everybody got that? That should be the size. Now, we were talking about condition when patient might be risk of bleeding and excessive bleeding, and you may have to give certain clotting factors. You may have to give them blood, that you call fresh frozen plasma or packed RBCs when you have to infuse that when patient is high risk. So another aspect which is important, I want as an RN, which is important for you to know, is when you're infusing those factors, you're giving them a blood infusion, packed RBCs, fresh frozen plasma. It is important that you stay with the patient for the first 15 to 30 minutes or until you take the first vital signs after starting the infusion. You can delegate it afterwards, but that's real important that once you start that infusion, you stay there 15 to 30 minutes, or technically saying that until you take the first vital signs after that infusion. That's also very important because that question falls under in the NCLEX criteria, delegation, what you can delegate, what you cannot delegate. And this is one of the points that you can delegate, but you cannot delegate until you do this. Okay. Once again, do not aspirate. I just told you that. Can cause hematoma. And this is just the same thing coming up again here. Monitoring the lab values relevant for we're talking about APTT and then PTINR, and then knowing the antidotes for these medication. And I always tell them, for example, if they're going to take low molecular weight heparin, then enoxaparin at home, right? So it's injected the similar way in the tummy, how the insulin is, right? So always give same kind of instructions that we rotate the site of injection. Okay. This is just a repetition, guys. With just a few slides, and we're taking a break. We've been talking about the patient at risk of clotting or bleeding because of the drug factor. Now, you will find, especially older patients, that they're taking supplements, vitamins, herbal products. Somebody told him this is good for this, that is good for that, and they're kind of mixing it up, right? And you have no idea what they're taking because it's not on their chart. It's not filled at pharmacy. Somebody told them, they went somewhere, they got it. But these things can put them at a high risk. Okay, high risk, such as the medication listed here. Okay, like your ginger, garlic, ginkgo, capsicum, St. John's wort, feverfew. They are taken with those drugs, such as like warfarin. Patient might be at high risk of bleeding. So educate them about that. That's very important, okay? Because it's about interaction. It's that angle that you prevent an interaction or keeping your patients safe, because if they are taken together, patient will be at high risk of bleeding. So this slide is also very important. Educate them. Hey, you are on this medication, which increase your risk of bleeding. So make sure that you do not get involved in kind of extreme type of activities or games. If you get hurt, you're gonna bleed. Okay, and also tell them wear like some sort of medical alert, bracelets, so that if they ever got into a situation where they're bleeding, the others know that the patient is at high risk of bleeding, so they can intervene. Okay. Okay, that's it. Any questions before we take a break, guys? Any question?
Could you go back to that last slide for a second? Thank you.
This one or this?
No, the ones with the yeah. That one.
Okay. Anyone? Any question, guys? Okay. All right. So you guys ready to take a break? Yeah. It's like you're tired that you can't even say yes. You just yeah. Yeah. Okay. Okay, guys. Let's take a break. It's 11:47. Let's come back right at 12. Okay. 3 minutes extra. Okay, guys. I'll see you in just a few minutes.
Thank you.
You're welcome. Excuse me. Okay, welcome back, guys. Come on, come on, come on. Let's wrap up. Okay, please turn your cameras on. All right, guys, let's move on. Okay, and okay. There you go. Last chapter. Anti-lipemic drugs. Simple means your cholesterol medication, okay? Cholesterol medication. So we'll know what the problem is, and then we'll talk about the drugs, important aspects related to if it's mechanism of action, adverse effect, interactions, or any other educational points. So first of all, if we talk about high cholesterol, means high lipids. High means hyper. That's why called hyperlipidemia. Lipids are high, right? What are those? Like your cholesterol, triglycerides. Those are high. And they are the major risk factor for your cardiovascular disease, such as atherosclerosis or heart disease, stroke, and all that. Many risk associated. So that happens usually over a long period of time with the plaque buildup in the vessels. Okay, this is like a normal artery, all clean, blood is flowing normally, no issues. But with time, the plaque starts building up and the passage becomes narrow. And that is what the troublemaker is. Now, at one point, it might kind of rupture and, cause a blood clot. And then wherever that lands, blocks further down, risk of heart attack, stroke, and all kind of stuff associated with that. Now, the drugs we talk about, there different classes of drugs, acts differently, certain or specific unique ways of giving them, and then specific concerns with that drug. It's not that all have the same effect or they have same sort of adverse effect. Now, when we talk about cholesterol, these lipids, right? So these are triglycerides and your cholesterol. So cholesterol, they're different divisions under that, for such as your LDL, which is your low density lipoprotein. And this is what called bad cholesterol. Please have that understanding that because it's called low density, it doesn't mean that it's the thinner one and the good one. Usually, general term people talk, oh, the blood got thicker, that's why. So this particular term does not define good or bad in here. Low density lipoprotein LDL is the bad guy. And I'll give you a little tip to remember which one is a bad cholesterol, which one is a good cholesterol. HDL, start with H, means happy. Happy cholesterol, good cholesterol, HDL. The other one is the bad guy. Okay? Even though HDL is called high density lipoprotein, but just remember in a different way that it's a happy one. We want it high, but we want the LDL low. Okay? And then there's another one called VLDL, which is very low density lipoprotein cholesterol, which carries the triglycerides and kind of, plays its role to the buildup of the plaque in the arteries. And then triglycerides, it's type of fat which is found in the blood. And with high amount increases the risk of atherosclerosis. And more commonly when it combines with that LDL increases the risk much more. Now, if we talk about hyperlipidemia, there are different types, such as like primary hyperlipidemia. And there's a huge role played by patients' genes. Okay, patient genes plays a big role in this. Now it's called familial hypercholesterolemia. So this condition with a high LDL cholesterol level, which kind of leads to an early onset of cardiovascular disease. Then there's familial combined hyperlipidemia. I'm just mentioning it here. You don't need to know everything in here, just a basic understanding. They have increased level of cholesterol and triglyceride, which puts them at an increased risk of coronary artery disease. And then there's familial hypertriglyceridemia, when the high triglyceride levels, because of their genes, puts them at a high risk of this condition. Then secondary hyperlipidemia is more common, what we call these days, okay, because of lifestyle factors. What we eat, what we drink, what we do, and what we don't, right? We're doing what we shouldn't be doing, and we are not doing what we should be. So it's completely opposite what we're doing. Diet is what we select. Oh, I don't have time. What is quick? It's not about what is healthy. And sometime, not just sometime, a lot of time these days, we think what we are eating is healthy because somebody told us it's healthy. You know how years ago that Jared ad with these subways? I like, oh, it's so healthy. And what's healthy? Everything coming from there, even the dough. What is healthy? What is fresh? As a meat, again, coming from the plant, packed, opening up there. But just making the sandwich, filling it up, doesn't make it fresh. All ingredients are still old. You're getting the tomatoes from the warehouse, okay? You're just cutting it there, means makes it fresh? No. Well, but they were advertising, and people believe it. Don't believe these things. Okay, that's how they influence customers' thought process. Their products, every few you will find like a new trend in the market, and then it will disappear. They just, throw that seed, grow it, reap it, and gone. Okay, you'll hear like keto diet, this diet, that diet, just all, I won't say it, but you know what it is. Okay, so watch what you eat. If not all, I would say majority of the problems any human being experience is based on what they put in. Okay, that's where everything starts. Just to save a little extra effort to feed ourselves healthy, we take shortcuts. That's where we mess up. You see how this diabetes, hypertension increasing day by day, and mark my word, look at the data now. Take a look at this data after 10 years. You'll find every other person suffering from these issues. Sadly, it's very unfortunate, but it's so easy to influence, and people believe it easy. Now, obesity, that's the second thing. Okay. Now, one is we are putting up too much than what we need. Diet is meant to fulfill the need, not for just taste. Okay, so people are eating more. And the second worst thing is don't have time to work out, myself including. Okay, I'm not blaming others. I'm part of that. You know, all are in the same zone, same boat we're riding, which is shaky. Okay, so that is a problem. Then because of these things, and to some extent genetic issues like such as in diabetes, but one of the biggest thing is about that what you eat and inactivity, all those things, that is causing high risk. Alcohol consumption, some other conditions like thyroid and all that, or maybe some medication can put them at risk. I'm gonna skip this. Okay, now remember here told you good cholesterol, bad cholesterol. So remember here, HDL is the happy one. We want it high. How high? Higher than 40. Higher than 40. Okay? And LDL, the bad guy, we want it low. How low? Below 100. Okay? That's what we want. And then comes the general criteria for total cholesterol. We want it below 200. Well, now let's talk about some terms here. The conditions, the problems arise from this hyperlipidemia. Arteriosclerosis means, or atherosclerosis, these are the thickening of the arteries. They become less flexible, elastic. Now, in case of atherosclerosis, it becomes hard because there's a plaque buildup over time. There's a fat, cholesterol, other substances, they're just getting settled down in the artery walls. And that buildup is called plaque. And it makes those arteries, and what is happening there? Blood flow, right? And when it becomes narrow, it's blocking the blood flow. And the plaque can burst and can lead to a blood clot. Arteriosclerosis, when the blood vessels which carry the oxygen and the nutrient from your heart to rest of the body, it becomes thick, stiff, and sometimes restrict the blood flow to the other organs of the body. Any healthy artery, it will be flexible. But with all these issues, it becomes more and more hard. And that is arteriosclerosis. One more time. If you see it here, this is the normal open, but when this plaque builds up, or maybe here, there, whatever, small, big, the passage from where the blood flows becomes thinner, smaller, and it's blocking the blood supply, and that is a problem. Okay, so we looked into which cholesterol we want high, which we want low. Different type of conditions can happen, like coronary artery disease, right? So because of the plaque buildup on the walls of arteries. So when we talk about these things, for example, like vasculitis. What is vasculitis? Now, this is inflammation of the blood vessels. Okay, inflammation of the blood vessels. Then if we talk about Kawasaki disease, what is that? That is also inflammation in the blood vessels, but it's more spread out in like throughout the body. Throughout the body. It's more widespread. And this is more in younger patients, below the age of 5. Then condition polyarteritis nodosa, that is more like a rare condition, where this one also causes widespread inflammation, but it also weakens and damages small to medium size arteries. Okay, so it's just different type of issues. And another one like vasospasm. Vasospasm is when the arteries becomes narrow. Okay, and they're consistently contracted okay, called vasoconstriction, right? And the vasoconstriction now is reducing the blood flow, causing the vasospasm wherever the supply is reduced now. Okay. Now here comes the drug, the solution. Okay, as I said, we start with what? Non-pharmacology, right? And what's our goal? If somebody has a high high cholesterol, what's the goal? Reduce the risk of cardiovascular events, right? Heart attack, stroke, or anything. How? Bringing the cholesterol down. That's what the goal is. And there are different ways we could do, like non-pharmacological, diet, lifestyle modification, all including quit smoking, alcohol, those sort of things. And then comes the drugs if those factors doesn't work. At least 6 months tried, well, time to introduce the therapy. Or another scenario, at an early point, if the patient is at high risk, then we don't wait. Okay, from the beginning, you tell them eat healthy, exercise, manage your weight, look at the BMI, quit smoking, quit alcohol consumption. And now we're going to jump to the drugs. If this doesn't work or need combination, the drug of choice is statin. Statin. That's a generalized